right, welcome everybody to the Journal Club, which is supported by Seattle Science Foundation. My name is Chris Kepler from Rothman Institute and Thomas Jefferson University in Philadelphia, and the co-host is Greg Schroeder, who's also online. Tonight we're going to talk about something which, I'm not sure it's evolving quickly, but probably warrants some evolution in the treatment strategies for, which is the unilateral cervical facet fractures. And, I thought when putting together these few intro slides, I was initially going to call, this initially the historic Alex Vaquero facet fracture decision tree, which is unbranched. But I thought he might be on the call and that was somewhat insensitive. So we're just going to call it the historical Jefferson facet fracture decision tree. That is kind of how we've dealt with these. Most people got an operation. I think in looking at the way that we were making these decisions, it was sort of heavily biased by the Spectre paper, which is going to be discussed tonight. And so I don't want to steal the thunder for our fellows. But this ended up being the kind of basis for the SLIC's treatment of unilateral facet fractures. And, there are some problems with the paper, some limitations with the paper. And so we were always kind of like wondering if there's some better way to treat these patients out there rather than just, putting a plate or 4 screws in all of them. So without further ado, I'd like to jump into the first presentation by Sri Devi, and we will stop after each talk to have some discussion. Sri?
Sri, your microphone's still muted.
Yeah, got it. Sorry. Let me just go back to here. All right, so the title of this study is Clinical Outcomes of 90 Isolated Unilateral Facet Fractures, Subluxations, and Dislocations Treated Surgically and Non-Operatively. So this was a multi-center study that was formed by the Spine Trauma Study Group. It was done at 9 centers and included 13 surgeons. And just of note, in their disclosures, this is supported by an educational/research grant from Medtronic. So the rationale for this was that, at that time, this was published in 2007. There was a lot of controversy surrounding the management of these injuries, including like the diagnostic workup, the timing of closed versus open reduction, non-operative versus operative treatment, and then if operative treatment was chosen, the optimal technique of stabilization. Historically, facet fractures that included translation up to 25% of the AP diameter of the adjacent vertebral body were considered unilateral facet injuries. So if A divided by B was less than or equal to 25%. And then the amount of deformity was also sort of calculated with the amount of kyphosis via Cobb angle. These injuries are thought to involve a degree of rotational instability. So when the injured facet and lateral mass sort of rotates around the intact contralateral facet, you can imagine some rotational instability there. And there's also a degree of ligamentous injury that can occur to this contralateral facet, including the discal ligamentous complex and then the posterior annulus. So there may be a sort of a spectrum of injury, despite it being a unilateral facet fracture or subluxation, that may go uncaptured. And typically, if there's 50% subluxation, this was considered bilateral facet injury. And in addition, it's difficult to compare results of treatment because there's a lack of standardized and validated outcome instruments. The studies didn't involve a homogeneous population, inadequate power studies, and then there's also highly variable treatment. Previous studies all sort of identified superior outcomes with operative treatment. So the purpose of this multi-center study was to determine which patient measures specifically were associated with the best outcomes, and then which patients returned to normal general health status. So like I said, multi-center, 9 centers, 13 surgeons. They included patients with unilateral facet fracture, subluxation, or dislocation in the subaxial cervical spine, with subluxation less than or equal to 25%. Patients had to be neurologically intact or just a unilateral single nerve root deficit. Only acute fractures treated within 3 weeks were retrospectively included. Exclusion criteria included patients with cord injury, subluxation greater than 25%, second level of injury, those outside the 3-week window, and then patients who had significant medical comorbidities or unable to read or comprehend the questionnaires. So as you can see here, the plain radiographs and CT scans of the patients were assessed. They were then classified into 3 types, type A, B, or C. Type A includes facet fractures. So A1 is the superior facet, and A2 is an inferior facet, and A3 is a floating lateral mass, which includes a pedicle fracture as well as a vertical lamar fracture or facet fracture that basically dissociates the lateral mass. The type B injuries include a degree of subluxation, or B2, which is a perch, and then B3, which is a dislocation or a locked facet. And then it's type C, or a combination of the two. And they assessed patients with flexion extension x-rays of follow-up, and outcomes were assessed using the NAS cervical spine follow-up questionnaire, specifically the PD subscale, which stands for pain disability. So it's referred to in the paper as NAS PD. And then also the SF36 score, specifically the PCS score, and then the subcomponent of the PCS score, the bodily pain, or the BP component. So in the study, 90 patients were included with a mean follow-up of 27 months. 72 were operative, and then 18 were non-operative. So pretty uneven groups. Within the operative groups, they further subdivided patients into less than 18 months and more than 18 months. I'm going to reason why. And I believe it was 34 patients in the less than 18 and 38 in the greater than 18. Mechanism, about 49% had motor vehicle accident, 31% sports, and 20% other. Looking at table 1, if you go down to the bottom, length of stay was the only one that was significantly different between groups, with the operative group had a much higher length of stay than the non-operative, which makes some intuitive sense. I just highlighted here the median age because I found this to be pretty interesting. The median age for both groups were 16.4 years. So it's a very young cohort, and the mean is 33 in the operative and 41 in the non-operative. So it's a severely right-skewed, positively skewed distribution in both groups. Just something to keep in mind. And table 2, again, no significant difference in injury level, mechanism, comorbidities, associated injuries, or gender. But if you look at type of injury, significant difference there. In the non-operative group, the vast majority were type A, and within type A, there were A1 fractures, so non-displaced superior facet fractures. And in the operative group, they were highly varied. I mean, almost sort of, pretty equally distributed between the 3 types. Other results they noted was that no difference in neurological involvement, such as root injury between subgroups. No complications were identified in any patients. They attempted to do multivariate regression for the 3 outcome scores as the dependent variable. The only significant difference that was found was that being in the long-term operative group, which greater than 18 months, was significantly predictive of a higher PCS score of 6.7 points compared to the non-operative group. And this is controlling for age, mechanisms of injury, and comorbidities. The other 2 dependent variables, which was the NAS PD score and then the SF36 BP, was not significantly statistically significant, but as we will talk about in the next slide, the authors noted that it may be clinically significant. Going down to table 4, one of their goals of the study was to see how these patients, compared to baseline normative patients. So looking at the top row, you see that the mean of the all operative group was 85, and then for the NAS PD, and that's compared to all the way on the right, 89.1 the normative group. So that's significantly lower, statistically significantly lower. And same for the non-operative and all, which was again lower. And same thing for the SF36 BP, for the all operative, non-operative, and all was lower than the normative score, which was 75.2. This was not the case for PCS statistically. So sort of just summarizing these, basically the authors note that when comparing outcomes to population norms, it appears that the patients returned to near normal levels, but statistically significantly lower in a couple of the outcome scores they looked at. So they note that there may be more pain and disability in both the operative and non-operative groups. So if you have this facet fracture, you'll get back to somewhere near normal, but it'll still be worse than if you didn't have an injury. When you did multivariate regression for the operative group with a long-term follow-up, you had better PCS scores. And while the NAS-PD and the SF36BP scores did not reach statistical significance, they mentioned that the effect size may be clinically significant at 8.77, 9.34. And then authors also note that all floating lateral mass injuries, there were 4 of them, were all treated operatively and with posterior instrumentation. There are several limitations. It's a rather small cohort with uneven groups, low numbers in the non-operative group, and they all included mainly type 1, A1 fractures, and which are sort of less severe. And then they also allocated the operative group into short-term and long-term operative groups with 18 months as the cutoff, because it was noted that they better trend towards better outcome scores at sort of that point, at that cutoff. So with that, there's some retrospective sort of selection bias with this, and then there was selection bias going into it because patients with more severe injuries were allocated to the operative group. In addition, as I mentioned when we were talking about the multivariate regression, they thought that a couple of scores were clinically significant, but if it's not statistically significant, I don't know if we can say that. And then MRIs were not routinely performed, so it couldn't really assess other nuanced injuries to like the discal ligamentous complex. So we'll stop there and we can sort of further discuss that.
All right, thanks, Sri. Great job. So when you're looking at this, what's your kind of like take-home point from this? What should the viewers know for one line that you would know about this article?
I'd say one line is most people are treated with surgery, and these people all get back to near baseline, but are not the same as those that didn't have injuries.
Right. I mean, I think that's true, but I think one of the hard parts about this study is they clearly included patients who obviously needed surgery, right? To me, when I read this paper, like it's not a question. Should you treat somebody with a unilateral facet dislocation surgery or bilateral facet dislocation surgically, or for that matter, even a floating lateral mass, right? I mean, these are all clearly unstable fractures, and they kind of lumped them all together with what they classified as like A1 and A2 fractures, which are questionably unstable fractures. So when I look at it, I'm trying to figure out exactly what it means. And oftentimes when you go to meetings or when you read articles, they'll kind of use this study to justify saying, hey, listen, we should operate on all of these. But when you really break it down, it's like, that's not really what it's saying, because what's really being said is if you include facet fractures that are obviously unstable, well, you should operate on them. But okay, right, we know we operate on unstable injuries. The question is really which isolated facet fractures are unstable.
Yeah, Chris, I agree with you. It's pretty disappointing because this is a high-powered AO group of a multi-center study, and it really doesn't give you anything you can hang your hat on. And really, the fracture we all kind of agonize over when people ask us the question, if it's a stable unilateral with a little bit of nerve root irritability, that you have to operate on, or can you treat it in a collar? That's the one we'd really like to be able to use this group to and help us answer the question. I don't think this study really did that at all.
Yeah, I have 2 questions. One is anybody on the call a part of this paper? Because I cannot believe that the median age actually is 16. That seems like a typo.
That's what I thought as well, but seemed like that would mean, like half the patients are 16 or less.
It seems unbelievable. Yeah. And this is the second thing is I think what it shows you is you get a bunch of people in the room, and this has been our experience, and everybody thinks, yeah, we do a ton of these, and then when you actually drill down and you see what patients you have follow-up on and where you have x-rays on and what the numbers actually are, you don't have as many of them as you think. And you end up publishing sort of a hodgepodge group because no one has 95 unilateral facet fractures. They just think they do.
And Chris, I would make one other comment about that. So when we're trying to validate the new AO spine classification, and when we just look at the A, B, and C's, we can validate it with moderate to good reliability. But when you look at validating the facet fractures, we have absolutely horrible reliability, which means that even if there are people who think that they have a lot of them, we can't even decide what a real facet fracture is and what is a lateral mass fracture and what's a floating lateral mass fracture.
Fracture.
That it's really hard to get the literature to give you a clear answer no matter what you try.
Dr. Sasso, anything to weigh in? You want to weigh in on this? I saw him on there with his headphones.
Yes. Can you hear me?
Yeah, we can.
Yeah. So I think you've all hit the nail on the head. This is not really a prospective randomized controlled trial. This is a retrospective look at what may not even be the same type of injury. I mean, an injury that spans something from fairly stable to severely unstable. And so I'm not sure what information this actually gives us, other than you can operate on these patients and they do okay.
They almost make it back to normal.
We're not hurting them, by operating on them.
That's always our goal. Don't hurt people when operating on them.
Exactly. It'd be super nice to have a defined set of patients that were the same and that we were able to prospectively look to see whether or not surgery made them better than if we treated them non-operatively. But I think that's what they try to do with this, but that's not the information we get from this.
All right, well, let's button that one up and then move along. If we could switch the controls back over.
All right, I'm Vadim Gaz, and I will be presenting the Spectre paper. Let's see if I can figure it out. There we go. Can you hear me okay? Okay, cool.
Yeah.
So this is an older paper from 2006, but frequently cited when it comes to the non-operative treatment of unilateral facet fractures. And it's worth kind of delving into the details here. The purpose of the study was really to identify CT characteristics that predispose these unilateral facet fractures to failing non-operative treatment. So this is a retrospective study out of a single center of 24 patients with unilateral facet fractures that were initially treated non-operatively. It's worth looking at the exclusion criteria that include lateral mass fractures, contralateral facet dislocations, polytrauma patients if the polytrauma injuries affected the treatment, patients with multiple cervical facet fractures, although you can have unilateral facet fractures at multiple levels and still be included. And then I think the important one to note is patients that underwent immediate stabilization, and that was up to the discretion of the surgeon, were not included in this.
At Jefferson, right?
At Jefferson. So they somehow came up with
For everybody.
But by and large, he said, look, we looked back on these patients and they really followed the Punjabi and White criteria of if there's 3.5 millimeters displacement or 11 degrees rotation. That's like pretty much who these immediate operative patients were, and otherwise they tried to treat these injuries non-operatively. They took a lot of CT measurements measured by 2 independent blinded observers, and there are 3 that are worth really honing in on. The one all the way on the left is the articular height, and that is the length of the articular surface of the fracture fragment. And that's different than the absolute height, which is that middle image. That's the cephalocaudal height going from kind of the tip of the facet down to the fracture. And then other measurements were relative to the contralateral lateral mass, and that's the cephalocaudal tip-to-tip height which is depicted in that rightmost image. The results, so 24 patients with 26 facet fractures, and the two cases, both of them had C5 and C6 unilateral facet fractures, and they were actually successfully treated non-operatively. So I don't think this confounded the analysis too much. A quarter of these patients had radiculopathy on presentation, and that included pain and sensory changes as well as weakness. And only 2 of these 6 patients eventually underwent surgery. So that's another good thing to note. And then probably the most important thing to note is that only 5 cases failed non-operative management. So all of these risk factors are really evaluated, via these 5 patients. And the average time to surgery after failure was just over 5 weeks. So the CT risk factors that they found, the articular fracture height had a statistically significant difference in the failed non-op group, as did the absolute fracture height, average about 1 centimeter in the success group and almost 2 centimeters in the failed non-operative treatment group. And the absolute fracture height expresses a percentage of absolute height of the intact lateral mass, 41% in the success group, 55.5% average in the failure group. The graphs on the bottom depict each patient in the study for those criteria. And if we pick the middle one, which is the absolute fracture height, it's just important to know that there's a decent amount of variability there. So some patients with larger fractures had a successful treatment non-operatively, and some patients with smaller fractures failed non-operative treatment. So there's some variability in this cohort. So overall, the important take-home points here: radiculopathy and presentation may not be an indication for immediate surgery, as 4 of the 6 patients were still successfully treated without surgery. The study found that absolute fragment height over 1 centimeter or 40% of the intact lateral mass are at increased risk of failure of non-operative treatment. And although the articular fragment height was statistically significantly different, this really wasn't emphasized by the authors in the discussion. All the patients with fragments smaller than the criteria mentioned above were successfully treated non-operatively, but it's really important to note that about 2/3 of the patients with fragments larger than that criteria were still successfully treated non-operatively. And so it's important to know the limitations of this study. It's a retrospective study. There's some selection bias. A big part of that was, who was treated immediately with surgery and who wasn't. There's a very low number of patients that failed non-operative management, and there's no power analysis to accompany this study, which I don't think was as standard in 2006 as it is today. So overall, the big take-home points for me were: don't necessarily operate on radiculopathy right away. Probably the most important one is actually knowing how they measured fragment height and relative fragment height. So if you're going to quote those percentages and that 1 centimeter, know what you're measuring and the difference between articular and absolute fragment height. And then that really meeting these criteria is an indication for close follow-up. Maybe stand these patients up, get upright x-rays, and not necessarily immediate surgery. And the one caveat there is maybe patient dependability becomes a factor there, because if you don't think you're going to see someone in clinic after they present to the ER, that might impact your decision making. Thanks.
You're muted, Greg. Greg, you're muted.
Sorry, can you hear me now?
Yeah.
Thanks, Vadim. Great job. So one of the big questions that I had in your presentation was, you had these people who failed, but did any of them have kind of catastrophic failure, or was this just they failed radiographically?
So they didn't note the nature of failure. These people that end up paralyzed, or these people that end up slipping, 4 millimeters and end up getting surgery. I have no idea. I would only be guessing if I gave you an answer. They just said
right.
They considered failure late progression to surgery after attempting non-op treatment.
But that's a really important question for us when we're thinking about how to manage them, right? Because if the worst thing that happens is they develop a little bit worsening radiculopathy, then maybe we should make all of these people really fail, even if they're do meet kind of your criteria. Versus if they're becoming paralyzed, you don't want to wait on any of them. So I think that's kind of a major limitation whenever I read this paper that I think of as, I mean, I would assume that if there was some kind of catastrophic neurologic injury, they would have said so, but I'm not really sure.
I mean, I think we rely on this paper a lot. Like, this is sort of what we quote in our morning conferences in evaluating fractures. And I think that seen through the retrospectoscope of like the level of evidence and stuff like that, like it's like a little bit, probably not the best paper to be making clinical decisions on doing surgery on, particularly because when we're using like this one, very often we're like using this 1 centimeter, 40% sort of cutoff as saying, we're keeping these people safe. Let's do a surgery on them because we know if it's, this is the group that falls apart. But even applying the criteria, just to reiterate what Vadim says, applying the criteria of the Spectre paper to the Spectre paper patients, most of them get an operation they don't need.
Yeah, so let me. Can you guys hear me, Chris?
Yep, yeah, it's perfect.
It's a complicated topic because I could argue each way. I started initially treating these non-operatively, and then I had some high-profile failures where, people sent to me electively. It's always a weird thing. If you see a trauma patient, you take care of a trauma patient, you don't know who they are, you shake their hands, they meet you for the first day, you treat them, they may do well or fail. When they get sent to you because of who you are, and then they fail because you treated it non-operatively, I've been burned by these fractures, so I tend to, as people pick on me, be much more aggressive than maybe I should be, and I always fix them. And then I sit back and I go, okay, I don't have to worry about them slipping. So I probably am wrong being so aggressive, but I haven't figured out who's going to slip and who's not going to slip.
Right. We don't have another set of criteria.
Yeah. We tried to at Jefferson keep a registry, and we kind of did it for a while, but we didn't do it. I guess we just a massive registry accumulating all these patients and looking at them, and maybe we'd have more insight into the natural history.
I mean, I operated on 2 patients that showed up in my clinic last year that were less than a centimeter, less than 40%, and had fairly progressive weakness a week later. So I just don't think that this number really means anything. I just don't know which ones to operate on and which ones not to.
So, Alex, I think the question that was asked is, what happened when your high-profile patient failed? Did he just radiographically fail and then you're able to fix him and did fine? Or did he catastrophically fail?
So this is what happens when they fail. They come back and I start talking to them before I look at the x-ray, and they're like, I'm having a lot of shoulder pain. I'm having a lot of shoulder pain. It's neck pain, shoulder pain. And then I look at the x-ray and they've slipped. Now they're maybe at 4 or 5 millimeters and they're not feeling good. And I'm like, And then I go anteriorly, I lift up the vertebral bodies, I open up the frame, and they did better. So, I've learned over time when to be aggressive. So two areas that I'm very aggressive, and the guys will tell you, odontoid fractures and facet fractures, I'm very aggressive. If it's less than a centimeter, less than 40%, I could talk myself out of operating on a facet fracture. But if it hits that Spectre number, I'm just like, free pass, I'm operating.
Yeah. Yeah, I mean, we still quote it every week. This is like what we use as our yardstick. We're like right or wrong, but we're just waiting for some, if there's something better out there, we haven't found it yet.
I just want to comment that, as you guys were asking, like what the previous paper should have and probably could have determined was this question, like the type A1, type A2 in that paper is referring to these kinds of fractures. So if there are enough numbers out there, it could possibly be answered with like a bigger study.
Alex, what's your operation for these? You do ACDFs or posterior? Try to put the facet back and fuse it posterior, or both?
I'm a big advocate of going anteriorly, Jack, on these things. I've never had a posterior procedure fail. I've had anterior procedures fail. I've had floating lateral masses where I've gone anteriorly 2 levels, and they've subluxed. And I'm like, wow, I didn't undersize the graft. I thought I must have distracted too much. Never had a posterior procedure fail. Anterior procedure is so less painful. And if you could do an anterior trauma case, you become friends with the patient. You go posteriorly and they're miserable. So if I can go anterior, I will, but I've had anterior fail.
Yeah, when you go front, it's the most terrifying thing in the world is when you go front back and you plated the front, and then in the back you realize you can still move the vertebra around with a coker. It's just not, it's like the fixation is not that strong.
Exactly.
I had an in-hospital failure of an anterior cervical plate after a single level facet fracture last year or 2 years ago. Like the patient was there for like 2 weeks, because of other injuries. And before they left the hospital, they got standing x-rays and like the plate was falling off.
Yep. I've seen that happen, Chris.
All right, let's move on because we're at 6:30. We're at the midway point. So let's go to the next article.
All right, so hi, I'm Karthik Shram. I'm also one of the Rothman Fellows, and I have the pleasure of presenting this 2019 article published in the Global Spine Journal by Stephen Paler and colleagues out of the University of Alabama on the clinical outcomes of cervical facet fractures treated non-operatively with hard collar and halo mobilization. And this is an expansion on the previous paper presented by my colleague, Vadim Gaz. So this study was a retrospective review, and the primary purpose of this study was to evaluate the rate of non-operative treatment failure for unilateral cervical facet fractures at single or multiple levels. The secondary goal of the study was to validate the utility of the CT-based criteria for identifying risk factors for failure of non-operative management that was just presented in that Spectre et al. Paper. So the inclusion criteria for this paper was any patient with a primary diagnosis of unilateral cervical spine facet fractures at single or multiple levels, and this included patients with both simple and comminuted fractures. And the exclusion criteria included fractures causing any instability causing spondylolisthesis, dislocated or perched facets, bilateral fractures at the same level, floating lateral mass, spinal cord injuries causing symptoms beyond an isolated radiculopathy, any thoracic or lumbar spine injuries, or any avulsion fractures of the facet being less than 1 millimeter in width. And then lastly, any patients who didn't have the CT imaging for validation or inadequate follow-up being less than 8 weeks. So during the initial study period from 2007 to 2014, more than 1,500 patients were identified, but only 134 patients met inclusion criteria for the study. An additional 46 patients had inadequate imaging or follow-up, and therefore the final analysis was performed on 88 patients. Of this group of 88 patients with 106 unilateral facet fractures, 21 were initially treated with surgery, and they all achieved a stable union. The remaining 67 were treated non-operatively, of which 56 successfully were treated, but 11 out of those 67 failed non-operative treatment and required surgery, resulting in a failure rate of 16.4%. So the group attempted to determine the factors that predicted failure of non-operative treatment and determined that age and gender did not play a significant role. However, they did find that the criteria previously proposed by Spectre of absolute fracture height greater than 1 centimeter and greater than 40% involvement were significant predictors of failure. Additionally, they also identified patients who weighed over 100 kilograms and patients who had fracture comminution, defined as greater than 2 fragments on CT cuts, were also predictors of non-operative failure. So this is just, again, a diagram showing what was previously presented by Vadim. So I'm just going to quickly skip over it. Image A on the left is just a definition of the absolute fracture height, how to measure that. And then image B on the right is the contralateral intact facet, and measuring the distance A over B is how you calculate the percent involvement. So looking at the successfully treated non-operative group, 48 out of 56 either had an absolute fracture height less than 1 centimeter or less than 40% involvement. In 8 of these 56 patients, they had both an absolute fracture height greater than 1 centimeter and greater than 40% involvement, and still went on to be successfully treated non-operatively. In the non-operative failure group, all 11 patients had both an absolute fracture height greater than 1 centimeter and greater than 40% involvement. So based on their results, the study found that the Spectre criteria to have a sensitivity of 100% and a specificity of 85.7%. And this study obviously did have some limitations in that there was a small number of patients with multiple level facet fractures, and therefore they could not analyze if this was a predictor of failure. Additionally, not all patients had MRIs, so they were not looked at concurrently to evaluate for any discal ligamentous injuries that could have contributed to failure in the non-operative group. So in conclusion, this study supports the previous criteria proposed by Spectre that a fracture height greater than 1 centimeter and greater than 40% involvement predicts failure of non-operative treatment. But the key difference here is that this study proposes that both criteria must be met to predict failure. They also identify that patients with comminuted fractures and those that weigh greater than 100 kilograms are also at risk for non-operative treatment failure. Thanks.
Thanks, Karthik. So, first of all, maybe this is may reinforce a little bit what I think a lot of people think about the Spectre data, or the Spectre paper, getting back to that again, which is that it's a conservative, safe set of criteria, right? You're not going to lose if you operate on people who have a bigger than 40% and a bigger than a centimeter fragment. The question is, is there a better number out there, or is there another consideration that would help you figure out which of the people under that criteria would get an operation that don't need it? And that's where I think the value in this paper may be in identifying the greater than 100 kilogram, the other predictors of failure. Again, I don't want to keep picking on Vaquero, but what do you think? What else is out there? Is there something better?
Yeah, Chris, I don't think there is. I think that we've been affected by our past successes and failures. You had just mentioned you had that case where someone failed on an anterior-cervical fusion. So these are the treatment things I keep in mind. If I distract and if I go anteriorly, that's going to fail. That's my trigger to go posteriorly on this type of fracture. If it appears to be somewhat stable, I'll go anteriorly. I tend to err on being more aggressive. If I definitely do not want to fail and I'm not worried about neck pain, I go posteriorly. But out of that, we just have to keep registries. We just have to cull these patients out. We just have to, pool our experiences together. It may be one of those studies that Dan Ruud did a while ago, where he said, "Listen, send me all the cases you have and your experience on facet fractures, rather than having a prospective cohort of patients in the registry." We then pool people and say, "Listen, send all your cases in." That may be the next best thing to do.
Yeah, but Alex, I'd argue that even that's not great, because if we can't have a good reliability between people looking at facet fractures and determining what it is, even if you have one person who says, "Oh, listen, mine is 1 centimeter and 40%, but what's 1 centimeter to me is very different to somebody else."
Alternate facts.
That's what the AO spine data said to me when we did that.
To Greg Schroeder, 4 centimeters is massive, so we have to keep that in mind.
Absolutely.
Yikes. All right, so let's tackle the last paper. Unless anyone else, I don't see anything. There's no questions on the chat. Keep them coming if anybody has anything they want to bring up. But in the meantime, let's move on to the last paper.
All right, thank you. I'm Chad Donnelly. I'm one of the fellows also. So I think Vadim did a really good job picking these papers and ordering them the way he did. We kind of had the diagnosis that we talked about. Then we talked about the radiographic features, and then we talked about the symptomatic features. So now we're going to talk about one of the surgical ways we could treat these and who fails and who doesn't. This is a very good 2004 paper that was in Spine. It was a radiographic review of 87 patients. Their inclusion level or criteria were unilateral and bilateral facet dislocations, as well as fracture dislocations, and all of these patients were treated with an ACDF procedure. These were all one-level cases. The ones that they excluded are those that were some of the polytraumas, treated corpectomy, if they had other underlying things going on like infection, cancer, or if they had other cervical spine injuries. The goals from this paper were to report the incidence of radiographic failure, to identify who are these people that are failing, and identify the people that are not fusing these fixations. Go to the next slide, please. Perfect. So here's kind of an example of what they're talking about. So the image on the far side is going to be showing that there's a bilateral facet fracture at 6-7. They're going to treat it. It's going to be the immediate post-op film. They're going to have measurements I'm going to show on the next page. And then if they failed, as you see in the far picture, that's obviously an example of a failure. So what they did is in these retrospective review of the 107 cases, they had 87 with complete radiographs that they were able to include. And they defined a radiographic failure as a change in translation of 4 millimeters. And they also had a angulation change in 11 degrees between the immediate post-op films in their most recent follow-ups as another assessment of failure, in addition to the lack of fusion. The results, they had bilateral facet fractures in 75% of the patients, unilateral facet fractures in 25% of the patients. And of all the patients they had end plate fractures in 17% of these. What this translated into is at the time of the injury, they're able to see the amount of displacement they had, the amount of dislocation in translation they had was obviously higher in those with bilateral facet fracture dislocations, as you'd expect. The kyphosis is also larger in that group. After the ACDF, the translation was corrected to almost 0.3 millimeters, and the alignment was corrected on average to 0.45 degrees, and that reflects more the normal kyphosis you would see. Sorry, the more normal lordotic alignment. At final follow-up, the mean translation was 0.9 and maintained alignment of 3.6 degrees, and that was suggesting that there was more normal lordosis in the majority of cases. So then they looked at which patients failed. So radiographically, they had failures in about 13% of these patients. Of these patients that failed, 64 of these patients also had a non-union. They looked at those that had a union but still failed unacceptably, and they included those also. So then they decided, now we know kind of this criteria, who fails and who doesn't fail. And they found that those patients that are more likely to fail based on angulation and translation are those with an end plate fracture, as well as those that have a facet fracture. Those that are more likely to have a non-union are those that have an end plate fracture. Those that did not fail, which is also an important thing to note, are, this did not reach significant, but it trended towards there, as those that have improved lordosis on their initial post-operative films and those without facet fractures. They had worse translation on the initial post-operative films and those with facet fractures. They found that there's no correlation with radiographic failure in age, gender, if there is a unilateral versus bilateral facet injury, or if the level, like the C3, 4, 5, 6, 7 injury. There's the initial degree of translation or sagittal alignment. They said these were also not indicative of who would fail and who not, and who would do well from the ACDF. So kind of the take home from this paper is those with like a flexion distraction injury of the C-spine. What does that mean? Who are the patients that are going to do well? Who are those that are going to do poorly? A one-level ACDF, they determined, is not a reliable treatment for facet fractures, both unilateral and bilateral. When there's adequate lordosis that can be restored and the facets are intact, these facets will offer resistance to anterior translation. So they said that if there's facet fractures and there's no buttress, there's a higher shear force, higher failure rate. They also argue that in the one-level ACDFs is not a reliable treatment if there's an end plate fracture, especially if this is a superior end plate of one of the lower levels. This may lead to the interference of the fixation with the screws of the caudal vertebral body. They argued that a one-level ACDF failure was not associated with the initial injury kyphosis, and that a one-level ACDF is reliable for facet dislocation treatment. What they did not address is how much do these radiographic failures even matter? That was mentioned earlier by Dr. Schroeder. It says, do these failures have worse outcomes, complications, or revisions just because they failed radiographically? How does that correlate symptomatically with these patients? That was not addressed in this paper. There's a similar paper that was a follow-up to the study almost 13 years later. And what they found in this follow-up paper, Skip had mentioned, they looked at 36 patients that had bilateral dislocated facets that were treated with ACDF. In their group, they found a failure rate of 8%, which compared to the paper I mentioned of 13%. They also looked at end plate fractures, which they said that 43% of those end plate fractures failed. They looked at those with facet fractures and said 4% of those failed. So in the time was similar to other mentioned papers, about 4 weeks of failure. So in this paper, which is similar to the one I presented, they had a facet fracture. It said the facet fracture might not be a risk factor. There's a text over there. Might not be a risk factor for failure, but in the absence of an end plate fracture in ACDF, it could be a reliable treatment option for patients with a single level facet dislocation.
All right, thanks, Chet. I think there's like kind of two big takeaways from that paper. One of which is the end plate thing, and Dr. Arlay from University of Pennsylvania in the chat had just suggested the same thing, that the anterior surgeries fail with end plate fractures. The other thing is that it also seems like, maybe on a little bit longer time horizon, there's a premium placed on achieving fusion, in as much as eventually, like, fusion surgeries are a race between instability and fusion. And if you lose there, then the thing falls apart. And so, like, you didn't break the guy's neck. He comes in with a broken neck. Can you make a case here for, like, going all in on the old school autologous bone from the hip? Dr. Neil Anand, can you sell it in LA? Or are you really not there? 1, 2, 3. All right, fine. Moving on.
Neil Anand has a robot name. He's never on any of these calls. It's just a robot that always signs in for him.
So, but really, can you make a case for autograft or something like that as far as the non-union part of this? Maybe. Like, again, you didn't break the guy's neck. He broke his neck on his own.
If I were going to do that, I'd just put screws in the back, though, because I don't think. The risk of failure is so low with a posterior fixation.
Yeah.
These are the cases, Chris, I go front back on. If I have an end plate fracture with a fracture subluxation, I have a low threshold for an anterior posterior procedure to keep it single level.
Okay.
Or if they're old, just do 2 up and 2 down in the back.
Okay, so I would say I would usually do single level in the back. All right, let's go around. Dr. Blumenthal. Single level end plate fracture, single level unilateral facet injury, front back, or only posterior, or what?
Well, it's interesting. I was just about to chime in and ping Rick Sasso, because I think he did the Chicago Trauma Fellowship a year or 2 after I did. And these bilateral facet, jump facets with posterior element fracture, they're tremendously unstable fractures, and anterior alone's not going to cut it. So I think you do have to go front back. And back then we didn't, have lateral mass screws. We were just doing wires. So we had to go further above, further below. But I think you can just go at the level of the injury now with modern fixation. But you got to treat. You got to treat the pathology. If it's anterior posterior pathology, you got to go where the action is and treat everything.
The interesting thing is even with the era of posterior wiring, we did a systematic review, which a large portion of the papers captured were in the wiring era. Posterior fixation, even with wiring, still beats ACDF.
Yeah, but all those patients probably have autogenous bone.
Right. Sure.
In the days before, when you guys were born, back at Rancho Los Amigos, we had the worst patient population. They were so bad that LA County turfed those patients to us. So when we reviewed, 113 of those patients, they had 100% fusion rate with wires and autogenous bone in the worst patient population that you could, and the most uncooperative patients you could find. So there's something to it, but it's probably, a little bit of fixation and a lot of biology posteriorly forgives all sins.
Jack, did you
treat those with a halo?
Do you use a halo?
That's not, no, postoperatively we put them in a hard collar. For some reason we didn't operate on them. Obviously they did halos there, but they were hard collar patients.
Yeah, so 2 questions.
Most people don't want to be in any hard collars or any halos. So our fixation is so robust today that we've sort of forgotten the biology and let the fixation take over for it. In most cases,
yeah, the 2 things that went away, and Rick, you remember the autographs that we used to take in the fellowship there. If they were a complete quad, we used to take tibial autographs. There were some amazing autographs we used to take. And I was going to ask about one of the papers, which was talking about non-surgical treatment with a halo. You just don't see a whole lot of people in halos these days. The morbidity of just going ahead. If it's halo worthy, the morbidity of just going ahead and operating on it, like Alex said on the unilateral facet fractures, just do the surgery. A halo is much more morbid than an ACDF.
Yeah, I think like just kicking back to the very beginning of this whole thing. That's like sort of the takeaway from the first paper was that, like, post-op, they kind of get back to being normal people. Like it's not, a single level ACDF or whatever is not a real big detriment, even with the.
So, Chris, what's the take-home message for the fellas?
Take-home message for the fellows is where I think we are now, which is that anything that shows that this is an unstable injury, you fix it, right? Like you didn't break the guy's neck. Number one. Number two, a fracture that seems stable, then it's like you got to round on the patient and see if you think this is a dirtbag or this is a person that's going to come back, because that's like the next decision point. It's like if that person's not going to come back, like then do them a favor, do a single level surgery and get them out the door. And if they're going to come back and you can see them in a week or two in clinic, then we don't operate on them if you can avoid it. And it's like kind of like it's a little bit of an unsavory answer, but I think welcome to Philadelphia.
Yeah, and Chris said the most important thing, you have to see these people back in a week, because if you see them later and they slip and they're in a bad mood, you never lose if you see them in a week. And you say, listen, things may change. I may have to operate on you. They'll never get angry at you.
Let's see. I think we have there may be a couple chat things. Okay, so I can't see the name. Neil is multitasking. Someone wrote that they use tricortical bone for ACDF on trauma patients if they smoke. If it's a bilateral facet fracture, they do front backs, similar to what Dr. Vaquero said earlier. And then I can't see the person's name because I don't think I had my window big enough. But the point is what's the downside of a 1.5-inch incision and a little wedge of bone? Not that much. You probably can't sell it in LA, but you can sell it when you didn't break the person's neck. And agree, thanks. Any other pressing issues someone wants to bring up? Anybody have an axe to grind? Fix them all?
Hey, good job. I think this was fun, like taking one particular piece of pathology and then looking at it several different ways. So, thank you very much for doing this, guys.
Yeah, thanks, Chris. That was really good.
Thanks so much. It was a good time. And great.
Listen, fellows, great job.
Next time we'll have answers, Chris, okay?
All right. Take care.
All right, stay safe, everybody.
Alex, I hope you enjoyed your ribs.
They were great. My iPhone is destroyed. My iPhone.
We saw you.
I gotta get another phone. It's disgusting.
It was disgusting watching you eat.
Just lick it like you usually do, Alex.
Exactly.
See you later. We should have recorded that.
Oh boy.
Should have.
Hi guys.
They recorded it.
Thanks for watching. Hit the subscribe button for more medical content.